Good morning. Thanks for joining us. Today we're going to talk about the EKG. One thing you want to do before we start is to review these videos. They're made by Khan Academy and I really like them. The first one on the sheet talks about the flow through the heart, how the blood flows into it, out of it, how that it pumps. It talks about the valves and the different things. Again, an excellent video. The second one is about the electrical system of the heart. Important information to know. We know we have the SA node is up here, the right atrium. It talks about how that the impulses are made and travel from the SA node to the AV node, and how that makes the heart pump. One thing, if you notice down here, the atria is in orange and the ventricle is in green. And you'll see how that the pump works, right? This beats, then that beats, and that makes the atria beat, and then the ventricles beat, and that is what makes the normal sinus rhythm. The P wave, the QRS, and then the T wave. Again, all three videos excellent. Each of the videos are less than 10 minutes in length, and I would encourage you to review them first. If you're looking for the links, if you found us on YouTube, you can find the links in the description. Today we're going to talk about EKG interpretation. We're going to analyze some strips, and when we do that, we'll be reviewing the rate, the P waves, the P to the QRS, and then the PR interval. This looks like a normal sinus rhythm. As you notice, you'll have the P wave here, the PR segment, the QRS, and then the T. You also have segments within them. You have the PR interval, the PR segment, the ST segment, and also the QT interval. So when we're talking about rate, what are we talking about it? This is generally an EKG strip. One thing I like to think about is each of the big boxes is 0.2 seconds. So if you have 5 boxes, then that would be a second. So this strip shows what a 3-second strip would be. You can take a 6-second strip and multiply by 10. So we'll pretend we have a 3-second strip. So if we have 1, 2, 3, 4, and then 4 again, that would be 8, and multiply that by 10, we would get that this heart was beating about 80 beats a minute. Okay, so you can see that the big box 0.2 seconds, the little box 0.4 seconds. So P waves. Are there P waves? What is the rate of the P waves? And what does the P wave look like? Is it smooth? Is it rounded? The QRS, when we look at it, is there a relationship of 1-to-1 with each P wave and the QRS complex? Then we look at step 4, the QRS. Are there QRS complexes? Is the QRS 0.06 to 0.12 or 1.5 to 3 small boxes? The PR interval. Is the PR interval between 0.12 and 0.20 or 3 to 5 small boxes? Those are all things that we want to look at when we're interpreting the EKG. So here are some rhythm strips. You see a normal sinus rhythm. Here's a first degree AV block, a second degree, and then a third degree. Here are VTAC, VFib, and then a third degree heart block. This is something that you'll see many times. Is you'll see normal beats, and then you'll hear hey, they're throwing PVCs, and that's what they look like. VTach, again, something that you'll see and become unfortunately familiar with if you work in ICU. VFib, looks like this. We'll be talking about each of these individually. Normal heart rate. This is definitely tachycardia. If somebody's having a myocardial infarction, this is what you'll see. You'll see the P, the QRS, and then kind of looks like a seat almost. So that's bad news. They're infarcting. And then you'll see over here we have some VFib and then heart block. Okay, so what is a normal sinus rhythm? The beat is usually 60 to 100 beats a minute. Are there P waves? Yes. So if you look here, we have P, QRST, P, QRST, P, QRST. So yes, there are P waves. Okay, and each of the P waves has a QRS, and then it also has a T that follows. What's the rate of the P wave? If you look here, so the rate would be the same as the QRS. So is it positive? Is it smooth and round? Yes, it is. That's good. So is there a one-to-one relationship between the P and the QRS? We just saw that. Are there QRS complexes? Yep, there are. And is the QRS and the PRI interval good? So that would be a normal sinus rhythm. That's what should happen. Normal sinus rhythm is a result of the electrical conduction, follows the normal path without deviation. So now what? So now we have the normal sinus rhythm. That's a great place to start. Now, what happens if things go wrong? So bradycardia is a heart rate under 60 beats per minute. There are two types. There's sinus bradycardia, and then you have an AV block. And of those AV blocks, you have first, second degree, and you have two types of those. Then you have third degree. So when you're looking at the EKG, you'll see that regular normal sinus bradycardia, you have PQRST. They're all normal measurement, all meet the criteria for the sinus rhythm. However, when you count it, it's less than 60. So here is a good example of sinus bradycardia. So you have the P, QRS, and T. You have those for each beat. Okay, so that's good. Heart rate is less than 60. It's regular. Something I like to do is when I have this and want to see how regular it is, I take a sheet of paper, a strip of paper, and place a tick here and a tick here, and then take that paper and move along the strip, and you can see any deviations in how regular it is. So what causes it? It can be seen in healthy adults, athletic, or it could be asleep. When I was in ICU, we had a few patients whose heart rate stayed in the 50s. That was normal for them because of some meds that they were on. Also, athletes can have a lower heart rate, sometimes in the 50s. But other things can cause sinus bradycardia too, including heart tissue damage, hypertension, myocarditis, hypothyroidism, lupus. It's common with an inferior wall MI. Also increased intracranial pressure, increased vagal tone from vomiting when someone is having a bowel movement. Also, there are some medications people can take. These medicines can slow the heart rate down. Beta blockers, calcium channel blockers, DIG, also opiates, and psychosis medicines can also slow the heart rate down. So what causes it? PACE is a good mnemonic. You can read it there. So what can happen? Patients with sinus bradycardia are usually asymptomatic. However, it makes sense that if they're exhibiting symptoms like an altered level of consciousness, hypotension, if they're having respiratory distress, delayed capillary refill, syncope, or shortness of breath, then you'll want to treat it. So how do you treat it? The first line is atropine, and the second line is dopamine and epinephrine. Also, if they're not getting perfused well, then you may use transcutaneous pacing. So what is AV block? There are 3 types. In the second degree, there are 2 types. I get confused with those, but I think that's normal. In first degree, there's just a mild form of heart block, rarely symptomatic. Very few times that this rhythm will receive treatment. The electrical signals are delayed. So we've talked about the SA and the AV node. They're basically delayed, and so that causes a long PR interval. In second degree block, you're having some signals that are not even reaching the, you're getting SA but not the AV, and so you get skipped beats. Type 1 is called winky block. The atria are pumping at a regular rate, but the ventricles are pumping slower. Mobits, conduction delay is below the AV node, so the SA node is firing regularly, but something is causing the beat to skip. Third degree is complete. Atria and ventricles are not communicating at all, so they're blocked. The atria are beating at 6 to 80, but the conduction is blocked, so the pacemaker is messed up. This can either be at the junction or the bundles, and they're having chaotic messages, and because the P waves represent the atria pumping, QRS the ventricle pumping, there will be more P waves than QRS waves. So now let's look at the strips. Okay, so this is a first degree. You have PR interval is consistently greater than 20. So P, okay, so there's where the P starts. There's a 5 block out. So that would be 20. So yeah, that's like 24. So definitely something going on. You got the long time between the P and the QRS. There's also usually with this a regular rate that's less than 60. Okay, winky block. You see we have a P, QRST, P, QRST, P, QRST, P, QRST, a P with nothing, and then it starts over again. You'll see the PR intervals from here to here get increasingly longer, right? Longer and longer and longer until it completely winks out or away. So you'll see the QRS is skipped here. Mobits, you have regular P to Ps, and again you see an extra P wave that doesn't have a QRS. Both of these have the chance to progress to a complete heart block. Bad news. Third degree, you can see here, very bad news. You're having multiple P waves without the QRS. It's just getting longer and longer and longer. This is a very slow rhythm. It's probably like 30 beats a minute or something, and so that's bad. So how do we treat it? First degree AV block, second and third, can be caused by an acute inferior MI. They're having a heart attack now. Right ventricular infarction, increased basal tone, ischemic heart disease, DIDGE toxicity, beta blockers, amiodarone, calcium channel blockers, electrolyte imbalances, rheumatic heart disease or myocarditis. Usually when I was working out in ICU, it was probably caused by an inferior MI or maybe DIDGE. The second one, Mobits, is caused by damage to the bundle branch. So what can happen are usually asymptomatic. However, they can faint, have heart failure, cardiac arrest and death, or hypotension. So how do you treat it? The main goal is depends on the patient and the goal. First degree, you might want to hold medications that slow the conduction. Second degree, if the patient is too bradycardic, you will give them atropine and possibly use pacing, but only temporary. The best outcome is if you discover why it's blocked and treat that cause. The Mobits, if the patient is asymptomatic, you'll use pacing and dopamine for the hypotension. If they're asymptomatic but not maintaining proper perfusion, you'll have the pacer nearby and ready to use. You also want to slow or hold all the drugs that slow the conduction. In complete heart block, a symptomatic patient who is bradycardic will need atropine and need to be paced by a transcutaneous pacer. Okay. The whole deal with all these rhythms is, are they being perfused? If they're not being perfused well, then things are dying. And we don't want that to happen. Sinus Tach, also tachy, is when the heart is beating more than normal. Again, you see P, Q, R, S, and T for all of these. The only problem is it's beating faster. The rhythm is regular. Well, you would take your sheet of paper. All those are regular. It's just very fast. So sinus tach causes decreased cardiac output because it's beating so fast that the ventricle can't completely fill. So there's increased oxygen demand, and a patient with sinus tach may have some of these symptoms, may be dizzy, lightheaded, have chest pain, palpitations, shortness of breath. They may say, hey, my heart's beating out of my chest. The best treatment is to treat the cause. If the patient has a fever, you want to administer antipyretics, Motrin, Tylenol. If they're anxious, you want to get the doctor or something to calm them down. If they have a narrow QRS, and treat them with vagal maneuvers or adenosine, beta blockers, calcium channel blockers, or sometimes synchronized cardioversion. So narrow QRS, treat them with that. If they have a wide QRS, then treat them with something like procainamide, amiodarone, or Sotalol. Okay.